Hi, I'm Balazs Halmos. I'm a medical oncologist here at Montefiore Medical Center, Albert Einstein College of Medicine in the Bronx, New York. So let me just talk about myself for a moment. We got hooked with COVID research for the last 2+ years, and I'm very glad that we have contributed in a number of different ways. But my day job is I'm a thoracic oncologist. I oversee the clinical research effort for our lung cancer and head and neck oncology groups, and I also manage the clinical trials office here at Montefiore. So very much involved with a number of different research approaches to make sure that our patients here at Montefiore Medical Center in the Bronx can have access to the best therapeutics that are emerging through clinical studies, and manage them safely and provide the right information to our larger public to advance science. Of course, New York City was the epicenter of the epidemic in March of 2020. In fact, our first patient, here at Montefiore Hospital was diagnosed on March 9th, 2020, if I remember correctly, just about a week after the first patient got diagnosed in New York City. And within just about a month, we've seen an incredible influx of patients with COVID-19 to the point that 95% of all the beds in the hospital were occupied by patients with COVID-19. And each and every week, we had to open new units, ICUs, to manage the very ill patients with COVID-19. Of course, this was very, very difficult, traumatizing for many, but also provided us in oncology kind of an opportunity to very early on initiate research to kind of understand the impact of COVID-19 for our patients with different cancer diagnoses. And from that early understanding of the tremendous impact, the very high mortality, especially for certain patient populations, patients with hematological malignancies and lung cancer being impacted the most, we've initiated a series of studies up until today, hopefully making an impact now in terms of our knowledge and in the management of patients with cancer diagnosis in the middle of the pandemic. Again, that early protection is exceedingly important. And we as a cancer unit have really introduced vaccinations very aggressively as soon as the approvals came in, I believe in January 2021. And ever since, we've been very aggressive to continue to follow each and every wave of vaccinations, booster vaccinations, and introducing other measures as well, such as passive immunization with antibody treatments for the right patients. Well, I'm very, very glad to say that the vaccines are very effective, and we were one of the first groups being able to describe it. And as soon as the vaccinations became available, we set up a number of different studies. First of all, to understand how patients recover from a COVID-19 infection. And we've noticed that most of our patients develop excellent detectable immunity after COVID-19, except for some patients with certain hematological malignancies, having received certain very immunosuppressive treatments that might just not have allowed that immunity to develop. And as soon as we started vaccinating our patients, we set up studies to understand how the vaccinations lead to immunity in our patients, and identified the same very high level of immunity in most of our patients with both solid tumors, breast, prostate, lung cancer, as well as actually many patients with hematological malignancies, mostly mild malignancies, but leaving a cohort of patients still vulnerable to a poor seroconversion. And these are specifically patients with different types of lymphoid malignancies, having received some very immunosuppressive treatments in the past. This knowledge allowed us to understand that this particular patient population needs to be protected in addition just to the standard vaccinations, and quickly allowed us to refocus on booster vaccinations, how booster vaccinations can still protect beyond the usual measures this very vulnerable group of patients. A key question is whether immune-compromised patients continue to be vulnerable to poor outcomes with COVID-19 despite the fact that they might have gotten vaccinated very appropriately. And the reality, and this is of course very unfortunate, but something we need to learn from, that yes, indeed, they do remain vulnerable. And we might have some tests to understand the level of vulnerability. Many clinicians are using antibody tests to sort of gauge if their patients might have responded to the vaccines. And we're seeing, fortunately, a wave of new measures, protective measures with antibodies that we can use, better antiviral medicines if a patient gets an infection, as well as now hopefully variant-specific vaccines that we'll be able to use that hopefully will continue to improve the outcomes. But yes, indeed, this cohort of patients require special measures, special attention, and our large hematological malignancy community is there to do that. So let's think about how treatments might impact the response to vaccinations. Of course, some of this is very logical. If our patients have received treatments that really impair immunity, and that can be very aggressive, treatments such as bone marrow transplantation, or very specifically treatments that are really going after the B cell compartment, such as anti-CD20 therapies, BTK inhibition, that might not allow the B cells to actually generate an antibody response. Very logically, those patients might have impaired immunity to most infections, but very specifically also vaccinations such as COVID-19 vaccines. And this is exactly what the science has shown. Our group has contributed to this, but many others have shown the same, that while the typical patient with a cancer diagnosis will respond really well to these vaccines with a level of immunity matching that of the general population, patients who have received these very specific, highly immunosuppressive therapies will have a lesser chance to convert. They will have lower levels of detectable antibodies, or they will not have detectable antibodies at all. And of course, they will remain more vulnerable to new waves of the infection with significant impact in the clinic. Well, of course, for the whole field, it's so important to continue to advance science so we can understand which patients respond to the vaccines, how well we can trust, potentially laboratory correlates of, vaccine-induced immunity. And this is where, fortunately, our laboratory studies have improved over time. We have better tests, to be able to detect antibody-mediated immunity. But now we also have emerging tests to look at the T cell compartment as well. And I find that very important, especially in patients who have received very specific treatments that might impair antibody-mediated immunity. Are we able to measure the T cell compartment that can still provide appropriate protection in a way from very poor outcomes? And I'm very, very eager to see how these continued advances will be making their impact in the clinic. Key question in the field, will we see the routine use of laboratory correlates such as antibody testing, T cell assays in our clinics, to manage our patients, to protect them the best, to understand their level of immunity. And I think we all recognize that this is an emerging field. At the moment, there's no clear guidelines as to the utility of antibody testing, but many notable clinicians are using that for their patients who seem to be most vulnerable, to guide the booster vaccinations. And not just that, but after appropriate vaccinations, getting a sense of the level of risk a patient might still continue to carry, and thereby being able to provide the right advice as to continued protective measures. And that can be masking, that can be social distancing, that can be maybe adjusting treatments on an ongoing basis to minimize the risk of infections. That can be other protective measures such as offering antibody treatments on schedule. I just want to state that as a lung cancer oncologist, that's not necessarily my area of expertise, and that I definitely rely on great guidelines from our transplant and other societies to teach us better. So while of course all of us remain excessively focused on COVID-19, let's not forget that our patients, especially patients who are highly immunosuppressed, are very predisposed to a broad spectrum of other infections. And being able to learn the level of risk, introducing risk mitigation strategies in terms of prophylactic antibiotics, antifungals, etc., are very important. And of course, close collaboration between our hematological oncologist and our infectious disease specialist is very important in the proper management of our patients after bone marrow transplantations, after highly immunosuppressive strategies, to come up with the best approach to minimize the risk of infections in these very vulnerable individuals and also to manage these infections if and when they emerge.